Physiowebseries Shoulder Complex Season 2, Series 6. In Series 5, we started scapulohumeral muscles. We covered teres major as well as coracobrachialis in Series 5. Deltoid is another scapulohumeral muscle which will be covered in this Series 6. So the origin as well as insertion of deltoid. Deltoid has origin from three parts or has three origins: from clavicle, from acromion, as well as from spine of scapula. So this will be the anterior fibers, this will be the middle fibers, and those will be the posterior fibers coming down on humerus to attach to the deltoid tuberosity. So this is the lateral view. We can see here there is this clavicular head or clavicular part, then the acromial part, middle fibers, and then the fibers coming from spine of scapula. So anterior, middle as well as posterior fibers in the lateral view inserting to this deltoid tuberosity. So in this lateral view, this can be appreciated: clavicular part, acromial part, and spine of scapula, those fibers. Similarly, it can be appreciated in anterior as well as posterior view. So anteriorly, the clavicular head can be appreciated well this way, as well as the acromial part also can be appreciated, and the back one, this one will be from the spine of scapula. In posterior view also, ahead over here there will be clavicular head, then there will be acromial part, can be easily appreciated in this view, and obviously the posterior view is there, so the fibers coming from spine of scapula will be appreciated going to deltoid tuberosity. So this is about origin and insertion. So as we saw, the anterior border and adjoining surface of lateral 1/3 of clavicle will have one origin. The next one will be the lateral border of the acromion, and the third will be the lower lip of crest of spine. So from the anterior border of the and the adjoining surface of lateral 1/3, as we saw in the diagram, it covers the lateral 1/3 and anterior border of the clavicle. Acromion also, the lateral border will be covered, as well as the spine of scapula. It will arise from lower lip of the crest of spine of scapula, going to insert to deltoid tuberosity of humerus. The nerve supply is the axillary nerve. So the axillary nerve is supplying the deltoid muscle. This nerve supply of deltoid is important as it has its clinical importance. So now the action of deltoid as per the fibers orientation. It arises from three parts: clavicular head, acromial head, and from spine of scapula. So the anterior fibers will do shoulder flexion, middle fibers will perform abduction, posterior fibers will perform extension. So anterior one along with flexion will perform medial rotation, middle fibers will do abduction of 0 to 90 degrees, and the posterior fibers will perform extension plus lateral rotation. So that is according to the fibers of deltoid muscle. Next comes the clinical aspect associated with this. Now if infraspinatus and teres minor, which are the rotator cuff muscles, part of rotator cuff. If there is weakness of those muscles, or if infraspinatus and teres minor are inhibited, then posterior fibers of deltoid will take over that role and they will become prime mover instead of infraspinatus and teres minor. So as the deltoid, posterior fibers of deltoid will act more in place of infraspinatus and teres minor, it will cause the humeral head to be forced anteriorly. It will cause the humeral head to glide anteriorly, as the posterior fibers of deltoid will do extension as well as lateral rotation. So while extension, if we go by convex concave rule, then the humeral head will come anteriorly. The shaft of humerus will go so if this is the humerus, this is the head, and this is the shaft. So in extension, the shaft will go posteriorly, whereas the head will glide anteriorly. So similarly, when the deltoid will work, the deltoid muscle, the posterior fibers of deltoid will become the prime mover. In case of inhibited infraspinatus and teres minor, there will be potential for humeral head to be forced anteriorly, to glide anteriorly, because of the force exerted by posterior fibers of deltoid, as they are becoming the prime mover. So that will cause anterior humeral glide, as we saw just now. The posterior fibers will cause extension of humerus. So the head of humerus will glide anteriorly by pulling humeral head forwards within the glenoid fossa. So this will cause the humeral head to be pulled anteriorly within the glenoid fossa, anteriorly or forwards. So this we can associate. We know the action, origin, insertion and nerve supply. So as nerve supply, the axillary nerve is innervating deltoid muscle. If there is some problem with axillary nerve, if axillary nerve is damaged, then there will be weakness of deltoid muscle. So if there is suspected weakness in shoulder movement as of abduction, because the initial movement will be performed by, initial abduction movement will be performed by supraspinatus, and later on deltoid will carry over it. So if there is some problem, there is pain or there is restricted range of motion of shoulder abduction due to weakness of deltoid, the reason may be damage to axillary nerve. So if there is any damage to axillary nerve, that means there is weakness of deltoid. Or vice versa, the reason of the weakness of deltoid is actually the damage to axillary nerve, which can be suspected, which can be one of the reasons. So here we end with scapulohumeral muscles, which consists of rotator cuff, teres major, coracobrachialis and deltoid muscle, which we studied in this series 6.